Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts, your host, and Healthline 3 is where we like to focus on ways to live a healthier, happier, and pain-free life. We'll be taking your calls and answering your questions live in the studio today. We'll be opening those phone lines soon, but as a reminder, just make sure you're in a quiet room when you call, with your TV turned all the way down so that we can hear your question. That number to call is 318-219-4569, and today's topic is all about the amazing advances we've seen in cardiology over the past decade, specifically talking about treatment options. And joining me today to talk about this is Dr. Phillip Rozeman, a cardiologist with Willis Knighton Cardiology. Thanks for joining us.
Thank you for having me.
Absolutely. So this is your specialty. You're a cardiologist. So tell me a little bit about, what is cardiovascular disease?
Well, I mean, it's a broad spectrum. The heart is, certainly in my view, and probably a lot of people, a very important organ, or the most important organ, because it drives everything else.
Right.
So in our heart, we have certain problems that begin to occur generally as we get older, but generally those are problems with the heart arteries, the blood vessels that supply blood to the heart, and making sure that if that doesn't happen well, that's when we can have heart attacks and chest pain and all those sort of things. Right. We have an electrical system of the heart that has to function well, because that's the ticker that basically brings blood all over your heart.
Right.
We have valves in the heart that also have to function well, and we have to have the pump itself. It's actually a pump, and it has to function well. And so anything that goes wrong in any of those areas of either electrical system problem, pump problem, blockage problem, these are things that come up as time goes on, and things that need to be dealt with. Yeah. And we've had a lot of changes over the years about how we approach heart disease, and then our success with heart disease. We used to do a lot of surgery. We don't do as much surgery as we used to, because we can do a lot of things percutaneously without surgery.
That's awesome. Yeah. And so there's many different facets within cardiovascular disease, so it's really important to diagnose it correctly.
It is.
Right. And so tell me a little bit about maybe some of these big risk factors, since so many people have heart disease or at risk for it.
Yeah, the biggest things you look at heart disease is first genetics. I mean, there are families that have increased risk of heart disease, and that's not something you can do anything about, but you have to be aware of the fact that if a lot of people in your family have heart problems, then that may be something you need to be very careful about. So how can you change that? Yeah. Well, a lot of it is with diet, changes in how you what you eat, cut the processed food. I tell people, a diabetic diet is probably a great diet for all of us if we could hold true to that. So the diet, and then we have risk factors, other risk factors involving the heart. Exercise is a risk factor. If you're doing nothing, then you have a problem. Smoking is a significant problem with heart disease. So all those things add up, and if you have a number of them, then you're at a high risk of developing heart disease, and you have to pay attention to things like what your cholesterol is, which is a big risk factors that we can do something about. With the old drugs we had for a long time, the statins, which have been monumental in how it's impacted positively, reducing heart disease, and now other new medicines that work on different pathways, that even if you can't tolerate the statins, now there's another drug for you, all right, that has been a problem for a long time.
Yeah, okay. And so now that we kind of have this understanding of what is cardiovascular disease, and now we're wanting to talk about how do we treat it once you've been diagnosed. So there's probably different ways to treat different conditions. If you wanted to start maybe with one, and we can go through each of them.
Well, let's start, first with coronary artery disease, which is problems within the blood vessels of the heart that generally occur as time goes on, and that's the part of having heart attacks and having chest pain and chest tightness, pressure in your chest, symptoms like that, shortness of breath, not getting enough blood flow to the heart. Atherosclerosis just occurs over time. It occurs earlier in some people than others. Sometimes it occurs in people in their 30s and 40s, but sometimes it's in 80s or 90s. So it's very variable. But we have a lot of things that we've changed in how we treat that now than in the past. Over the last few years, we've had stents that can be placed through blood vessels in your leg. Actually, you can actually put a stent and open up blood vessels of the heart. Those stents now have drugs on them that actually treat the place where the blockage is to prevent further blockage in the future.
Gotcha.
So these drug-coated stents and now drug-coated balloons have monumentally changed how we approach heart disease. Many things that used to require surgery no longer have to have surgery anymore. They can be dealt with percutaneously through, again, a catheter going through the leg and an incision that's, eighth of an inch.
Okay, and so that's kind of standard now.
It is. It's standard. But it's improved even more recently, because as these catheters get better, that is, the stents get better, and then the catheters, the platform that are to put the catheter on is smaller. These stents can go places that never could go before, and that continues to improve over time.
Gotcha. So if someone needs this procedure, they can, do you have to qualify for it? Or?
Yeah, it is. This is a treatment of blockage of the blood vessels of the heart. It's only to be used for severe blockage. Most of the time we try to deal with things with medicine as best we can, but sometimes people have more symptoms or have severe blockage, and those people are better off having balloon procedures and stents placed in order to open up the blood vessel, get more blood flow to the heart, and prevent heart attacks.
Gotcha. And so the symptoms that someone would have before is that chest pain,
it's
and
that
then
chest. Yeah, it's that chest pain. It's that chest tightness. It's a pressure in your chest. Sometimes it can be a toothache. Sometimes it can be a pain in the wrist. It's almost any pain above your waist can be that of a significant heart blockage and problem.
Wow.
So, but most of the time it's a tightness, a fullness, or feeling like heartburn, like your chest is burning. Those are symptoms to watch out for, and when you have those are symptoms you need to get to the nearest hospital, take care of.
Right.
And essentially it's symptoms that you need to get to the next hospital by 911. You need to call ambulance.
Instead of driving yourself.
Instead of driving yourself, if you have these persistent chest tightness or burning or really severe shortness of breath.
Right, okay. And so those symptoms improve after that procedure oftentimes?
Generally, oftentimes, marked improvement,
Yeah.
Marked change. People don't even have, a lot of times afterward, don't have any chest discomfort or pressure in their chest, and they do much better. And that's even people who have had this procedure done in terms of a heart attack. What we do now is totally different than what we did 20 years ago, in that when somebody comes in with a heart attack, they don't go to a hospital bed. Most of the time they go to a heart catheterization lab, because generally that means that the blood vessel is totally blocked. But if you could get it open with a balloon or stent, then it reduces the damage to your heart and really increases the length of life of people who've had heart attacks. It's a monumental change.
Yeah, that's awesome. And a lot of times it prevents a heart attack from even happening,
Right.
which is really important. Yeah.
Absolutely. And the sooner you get there, the better. The sooner you get taken care of, the better.
Yeah.
That's why we have a system in place in all of the major hospitals that have catheterization labs, so that when the patient gets there and they're having a heart attack, they can be quickly taken to be taken care of, no matter what time it is, day or night.
Right, okay. And so with cardiovascular or coronary artery disease, a lot of this comes into play with the cholesterol, right? And so getting on a statin is one of those medications that you would use therapeutically?
Absolutely.
Yeah.
I mean, statins have revolutionized. Again, I think it's probably the most important thing over the last 20 years is the use of the statins and the lowering of cholesterol, because you can't lower it enough with diet. If you have a genetic component, then you're not going to be able to do it with just diet to the levels that we believe are the best levels, which are continue to drop as we continue to learn more. The lower we try to shoot to get bad cholesterol, and the more we want to increase the good cholesterol.
Yeah.
But these and the statins work very, very well. But there are a certain subgroup of people who have difficulty with the statins. They have symptoms with the statins that they can't tolerate, muscle aches or aches, problems like that, or liver problems that really would keep them from having used statins. The last few years we have new medications that actually deal with different pathways than the statins, but do the same thing. They lower the cholesterol markedly, and they don't have some of those same side effects as the statins do. Again, the statins are the go-to medication, but these new medications, these are something for people who can't take the statins or cannot get where they need to go with just statins as far as their cholesterol. These medicines have been revolutionary.
Right. Okay. And that brings up a good point. So if someone was their cholesterol is high, and their LDL or their bad cholesterol is increasing, and they need to get on a statin, they have to go through that statin route first before these new medications.
Pretty much, yes.
Yeah. Okay.
And again, I'll just speak from a personal level. I have the genetic problem with cholesterol, and my LDL was 200, which is considered very high. And statins, I've taken the highest dose statin for years, and my cholesterol is about 65 now.
Okay.
My LDL cholesterol. So it does make a huge difference. They work very well, but there again, people that can't take them, can't tolerate them, have an allergy to them, whatever, these new drugs do the same thing as far as levels of
And what
reduction.
are those new drugs called?
They're the PCSK9 inhibitors.
Okay. Very cool.
And they're one of them you take as a sub-Q every 6 months, one that you take every 2 weeks, and then there's another one now that you take just like normal pills, to take one pill every day. But either of those medications, and the decision about which one might be better or worse, it's mainly around what you can do with insurance companies and what the insurance company feels like is the best medication. But all three of those are outstanding in what they do.
Very cool. Okay, and so total cholesterol, can you break these numbers down for me? Total cholesterol, LDL, HDL, what does somebody need to look for?
Yeah, total cholesterol, it's divided up between people who have never had a heart problem or relatively young, and people who've had a heart problem. For people who've had a heart problem, then the total cholesterol you want down around the 120 to 160 range. You want an LDL definitely less than 100, and maybe less than 70 if you can. And that's the goal. And HDL is hard to impact with medications, but we would like to have it, normal, which is over 40.
Okay. Is there any detriment to having a high HDL or a high good cholesterol?
Oh, definitely for a good cholesterol.
Okay.
I've seen this in my years of practice. When you see people that are 80, 90 years old, they look really good. They've never had any heart problems. A lot of times you can look and see what their HDL cholesterol is, and it's very high.
Okay.
Sometimes people have higher HDLs than their LDLs, and that really is it's a negative risk factor, meaning that it removes risk when your good cholesterol is normal or increased. The difficulty is that we've not been able to develop any therapeutics or anything that seems to be impactful in that area. So the concentration has been on lowering the LDL, which is the bad cholesterol, as low as you can go.
Okay, and so there's no, it's okay if you have a high HDL. There's nothing.
Oh, there's nothing wrong with that.
Okay, even like 100 and above. That's
100
okay?
and above is okay.
Okay.
Yeah. And actually reduces the need for other drugs a lot of times.
Okay. Yeah, because just sharing personal, for me, my total cholesterol seems to be a little bit higher. My LDL is fine. My HDL is very high.
Yeah.
But I always just worried, like, is that a bad thing?
You're at low risk.
Okay, good.
You're actually in better shape than the rest of us, for sure. So,
well, that makes me feel better. All right.
Rest well.
Okay, good.
You're in a good shape.
Okay, good. So let's say someone doesn't know what their total cholesterol is. When should they start?
Well, if you've got any positive family history, I would say start, checking your cholesterol even in your 20s. But generally speaking, for most people in their 40s, I know I checked it in my 30s and it was not too high, and then when I checked it again in my 40s, mine had gone up. So it begins to go up as you get middle age, certainly you need to do that, and women that maybe don't go to a primary care doctor, that go to the obstetricians need to check that and be part of the physical that's done.
Yeah, good to know. Okay, so transitioning gears real quick, chronic heart failure. I feel like this is a very interesting phenomenon. If you want to break that down, like what that actually means.
Yeah, chronic heart failure is kind of when the pump of your heart is not functioning well. There's a lot of causes to that. Diabetes is a cause of that, which is a major risk factor. Hypertension is a cause for that. That's a major risk factor. There are other causes of it. Coronary artery disease, when you get blockage and you have heart attacks and you damage your heart, that's a cause of heart failure. That's the major problem as far as length of life is concerned, is being able to preserve your heart function for as long as you can. And so there's been a lot of study being done about heart failure, because that's the major issue. That's the major cause of hospitalizations by double the next thing. In other words, if you go to a hospital and look at the diagnosis in the hospital, heart failure is double any other thing put together. So heart failure is a major issue, causes a lot of problems for people with shortness of breath and decreased exercise tolerance, and then the mortality, the cause of death from heart failure is significant. So again, there's been some significant work being done. We've come upon some medications now that are making big impact.
Yeah. One's
called Entresto, which is a combination of medications, and that medication works better than the other medications that we've had before in relieving the workload that comes with heart failure. There's some medicines that were originally looked at for diabetes, called Jardiance, Farxiga, originally studied for diabetes, but part of the study was that they divided people into people who had normal heart function and abnormal heart function. And what they found is that everybody who had heart failure got better with Jardiance and Farxiga. So it turns out that these medications, even if you're not a diabetic, they reduce your risk of death, they reduce hospitalizations, and it's a significant degree. So that's been a major change in medication.
Right.
We know that beta blockers are good, and we've had new medications associated with those. The big problem is we're learning all these things, and now it's becoming, there's 4 or 5 or 6 medications that you think about for people who have heart failure. So with heart failure, you're talking about a number of medications and drug interactions and all that sort of thing. it's complicated, but these medicines have also lengthened life for people and made life much better for the people that are able to take them.
Yeah, so the medications help the heart work.
Help the heart work, increase the heart function, a lot of them. They work to make sure, they work to have people live longer. In other words, even if the heart wasn't beating better, it turns out these medications, by relieving the workload of the heart, also significantly improves the heart function and reduces the death rate and reduces hospitalizations and all the bad things that you want to get rid of.
Yeah, and a lot of times with chronic heart failure, people will have like edema or the fluid retention. Do these medications also help that?
Yes, and those are the symptoms are generally with shortness of breath, tiredness, fatigue. Sometimes it's just symptoms, it's hard to tell whether it's heart failure or not. And swelling of your legs, those kind of things are symptoms of heart failure. There's some tests that are easily done, actually tests that don't even require a needle, called sound wave echocardiograms, which are stalwarts of my profession. And it's just a sound wave test like you look at babies, only we look at the heart. We can actually see how well the heart's contracting. We can follow how well it's contracting over time. You can look at all the valves of your heart. So it's a major test that we use all the time that really is the most important diagnostic procedure we have.
Gotcha. Very interesting stuff. Okay, and so we talked about coronary artery disease, we talked about chronic heart failure, and then arrhythmias is also another, maybe the electrophysics part of it, I guess. If you want to talk about that, maybe some treatments for that.
There's been a lot of changes. We actually have a whole specialty now in cardiology of electrophysiology. In other words, there's some people that come out and do interventions like I do stents and pacemakers, things like that. And then there's the electrical part of it. And they put in things called, it's a pacemaker defibrillator. It's a device that actually recognizes when you have sudden death, meaning you hear about people who die in their sleep. It's generally because they had some sort of arrhythmia. And these devices recognize the arrhythmia and actually will shock the heart back to normal. If the device wasn't there, they wouldn't survive the arrhythmia. And so those are major new things. Also, the dealing with a more common thing, which is atrial fibrillation, which is the most common arrhythmia. And over the last few years, we've been able to find the locus point of where initiates the atrial fibrillation, and can actually burn it or hit it with a cautery, or do it with a balloon, a cold balloon, find that area and eradicate that. And oftentimes we'll cut atrial fibrillation to nothing, not have it at all, or have it very infrequently. And so that's really changed things as it relates to atrial fibrillation. We also have new medications for blood thinners that we haven't had before in the last 10 years. It used to, you only had one medication, that was Coumadin, and that was the only medication that could be used. Now we have others that are easier to use and probably better.
Yeah, that's awesome. I love that. Well, we have our first caller on the line. Audrey, thanks for joining us, and what's your question?
My question is, I am 83. I have been going to the cardiologist once a year, and probably for the last 6 years, they told me I had a leaking valve, but it wasn't anything to be concerned about. So now I have like tired, shortness of breath sometimes. So I have not been this year. They keep pushing my appointment out. So I'm wondering, should I really be concerned about this?
The fact that it's been doing well over the last 5 or 6 years and not changed much is a good thing, and that means that probably it's fine. I do think it's wise to, if you're having symptoms, for your doctor to check it again. It's not an emergency. It's not anything like that. But having an echocardiogram to follow it from time to time is a good way of seeing if there's increased leakage. If you have a lot of leakage across the valve of the heart, then that puts a strain on the heart. But again, it's not a worrisome thing that it's an acute event, but it's something you want to check on to make sure you're not getting to a point in time when you have to have that leaking valve taken care of. I'll just add to that, in looking at the advances that we do, one of the advances is what we call mitral clips, which is a way to actually reduce leaking mitral valve, which is probably what is occurring in your case, and it does it by putting clips in that keep from having the leakage of the valve. So some people don't even have to have surgery for mitral valve things. So again, 2 or 3 or 4 years ago, everybody would have surgery, but not necessarily anymore. Again, sometimes these things can be taken care of with this new technology. But I wouldn't get upset or anxious about it. But certainly tell your doctor the next time you go you're having increased symptoms, and I suspect he'll check again with the echocardiogram. But there can be a lot of things that can cause the kind of symptoms that you have. So don't be anxious about it.
Well, let me ask you another question. Are you taking new patients?
Yes.
Okay.
Yeah, okay.
So.
And you're located at Willis Knighton Cardiology.
Yeah, we're Willis Knighton North, and I also have in Minden. But again, your cardiologist is on top of it. I think take care of it. So just work with them as you can. Okay.
Okay. Well, thank you. I appreciate it.
Thanks for joining us, Audrey. And we just have a couple minutes left, and we talked about most everything that we wanted to talk about. I think valvular heart disease, we just kind of talked about that. But last thing, pulmonary embolism, that always sounds so scary. Yeah. And so what is new in treatment for that? Yeah,
now we have a device called ECOS, which is a device that delivers blood thinner directly to the blood vessel where the blood clots are, and can significantly reduce the complications of pulmonary embolus. It's a very common problem, pulmonary embolus. It occurs a lot of times after surgery or when people are laid up. They get blood clots in their legs, and the blood clots break off from their legs and go to their lungs, and that's where it can be really dangerous. But this device, if needed, can reduce the long-term bad effects of pulmonary embolus. One of the things we didn't hit with the valvular heart disease is what's called TAVR, but it's a way to put an aortic valve in through the leg, through a smaller incision in the leg, rather than doing a big incision right here.
That's awesome.
And this is especially important in older people that previously couldn't have it at all because of the risk associated with surgery. So it's over time, these devices have gotten better and better and better, and continue to get better. Over time, I think it's going to be used more and more to prevent people having to have major aortic valve surgery. There's still some people that need aortic valve surgery, but it's less than it was in the past.
That's incredible. And just kind of to your point, what we started out with, you mentioned 20 to 30% decrease in mortality just over the advances that you've probably seen in your career with cardiology, which is incredible. So you're out there doing some great work, and we talked a lot about the treatments, and you do a lot of these treatments.
Yeah,
and you prescribe medications.
And we have people. A lot of times, this is becoming more involved in lots of different new things. And so what we tend to do in our group is to, different people learn different new devices. Not everybody learns all of them.
Right.
So that they can take care of most of them and get better and better because they have more and more experience.
Absolutely, yes. And Willis Knighton North, that's where you're
Willis
located.
Knighton North, the Heart
and
Center.
we've got the phone number located on your screen if you're just tuning in. This is the phone number to call to maybe get scheduled or send a referral over to Dr. Rozeman. Thanks so much for joining me.
Well, thank you for having me, and I really enjoyed it, and thank you for letting us talk a little bit about what I love, which
Absolutely.
is cardiology.
Thanks for joining us.